Not really, according to the length of the operation, because during the operation also we have been giving oxygen at least at 0.35 or 0.4 FiO2. We always give oxygen, although the present practice nowadays is not to give too much of oxygen. They are now using air just to lessen the, even if there is some amount of toxicity for a 12-hour surgery. If you give oxygen for at a FiO2 of 0.4, even that can be detrimental for certain subset of patients. So they are using air nowadays instead of oxygen. But even then, our current practice is to give oxygen during the length of surgery. So 2 hours would suffice.
Liquid oxygen and its clinical use.
Liquid oxygen basically when the use is very more and at certain pockets in a hospital complex. You've got a cath lab, you've got a cardiac center, you've got normal OT, you've got neurovascular OT, so these kind of situation, it is a bulk supply because the cylinders which we normally provide through, the cylinders are not very big. I mean, one big cylinder possibly will not suffice for too long. So it is a cheaper, although the installation cost is more, but finally it comes very cheap for bulk consumption. The storage is easier, although there are few stipulations for liquid oxygen.
Post-op oxygen therapy, can I add a few?
Yes. Very good.
Present day, actually what we have been practicing earlier was for washing out nitrous oxide, which we still use. Some centers they have stopped using it. The nitrous oxide washout, if you don't do it properly, you have a situation called diffusion hypoxia in the post-op. If we have not been conscientious in the reversal stage in washing out that nitrous oxide, even if the post-op is just close to the OT, when the patient is shifted to the OT, those things can occur in the post-op period also. So it is ideal to continue for 2 hours, and subsequently now with the laparoscopic surgery coming in, with the carbon dioxide pneumoperitoneum that we are having nowadays, there again if we do not conscientiously remove that carbon dioxide or make attempts to remove that carbon dioxide during the reversal stage, you can have problems in the post-operative period where you will be called suddenly patient has gone into severe hypoxia and pulse oximeter is showing so and so. So it's always better to have a support for at least 2 hours, and also the patient's efforts may not be as it was in the pre-op period because of whatever, the sedation or whatever, or even the pain that may restrict the respiratory excretions of the patient. So it is always preferable to have, but then always it is to be monitored. I think 2 liters is sufficient with the nasal pump. If there is no
because ideal situation, I mean, our room air contains 0.21 FiO2. So if we can achieve a FiO2 of 0.3, which is achievable through 2 liter flow in a nasal prong, I think that's fair enough for that particular patient. If the patient is not acutely hypoxic. The problem is it is never used as a drug. It is never used as a drug.
Sir, ये जो नया में जो hyperbaric chamber, they are creating and doing operation under this. What is that?
Apart from oxygenation, it has got many
Basically,
वही बोले इसलिए सर, what is basically क्या है?
Our concept is nothing else. Only concept is at the 2 to 3 atmospheric pressure, oxygen is delivered to the tissues. The tissues, particularly which tissues, the hypothesis behind that was to deliver oxygen at, I have shown you that delivering oxygen at the tissue level is the most important aspect. The mitochondria may work at 10 millimeter mercury or partial pressure, but the amount of oxygen being delivered to the dead tissues or supposedly going to dead tissues like burn patients or very old chronic ulcers and diabetic ulcers or things like that, there the oxygen carrying by the blood is also jeopardized because of the diabetic food or burn. Maybe the vessels are burned. So oxygen is not being delivered to those areas for healing. So you give hyperbaric oxygen at an atmospheric pressure of 2 to 3 atmosphere, so that you want to push in oxygen as far as possible. But there are a lot of pitfalls of hyperbaric therapy. Yes.
Do we have an oxygen concentrator and how does it work?
No, we actually, oxygen concentrators are not for hospital use primarily. They can be used, but because we have compressors, like in most of the ventilators we have compressors. They are the same thing, the purpose is same, only they are much more expensive. Concentrators are only primarily for household use. when we use oxygen for COPD or asthma patients.
So you don't need to store, you just, what do
You don't need to store, nothing. Cost of? Around 50,000. It actually comes in it along with the device. The oxygen tubing, the mask, everything, they come in the package.
Air, I think air is concentrated.
Yeah.
Air.
You don't need to have a cylinder.
Mane, the problem, again there is a pitfall of this, that you cannot achieve a very high FiO2 with this. So if you want to really give a FiO2 of 0.6, 0.7, then it won't suffice. Then you have to add oxygen through a cylinder. So the room air won't suffice.
COPD patient.
Yes, very good for them because they don't require very high FiO2.
Yes.
Sir, CPAP for sleep apnea, this oxygen
Hey, to light it,
both
everything.
are compatible or not?
Most of the devices are here in the table. You can
The
just
attachments have to be different.
particularly the students.
Contraption for sleep apnea.
Light it.
Incidentally, Dr. Chatterjee, in places where oxygen is not available in countries, they use oxygen concentrators for doing general anesthesia and surgeries.
Under.
In Africa.
In a place called Sierra Leone, Freetown, their hospital, government hospital, runs on oxygen concentrators which are fixed to their anesthesia machines. And the supply is about 4 to 6 liters and successfully surgeries done.
আমরা তো আমাদের হেলথ ইউনিটে গুলো
না, হেলথ ইউনিটে অক্সিজেন সিলিন্ডার তো পাওয়া যায় না।
Cylinder থাকে।
সিলিন্ডারে কি হয় না মাঝে মাঝে লিক করতে করতে অনেক সময় যখন দরকার তখন সিলিন্ডারটা খালি এরকম হয়
সে তো আমাদের টাইমে এখন তো এলজির
না, না,
টাইম
না,
নেই।
That's a good idea. The trouble of getting it refilled and the trouble of checking it, trouble of finding the spanner at the right time. Because
Yes.
recently I had the
Problem,
misfortune of asking for the spanner at the CKP hospital, and there was a lot of helter-skelter running everywhere looking for the spanner.
Exactly, it's
So
a practical
that
problem.
can be avoided once you have the oxygen.
Yeah, yeah.
But then again, that also